Welcome to Fuller Butz, a behind-the-scenes plastic surgery podcast. Yes, you heard that right. Join your co-hosts, Dr. Sam Fuller and Dr. Dan Butz, board-certified plastic and reconstructive surgeons, on an exclusive full-access pass into the world of plastic surgery. Combining their expertise and training, Doctors Fuller and Butz will share medical insights, detailed explanations, and lighthearted humor to keep you entertained and informed. We're certain you'll become passionate about the plastic surgery specialty, and between debunking myths, uncovering truths, or just making you laugh out loud at their perspective on this creative and artistic field, we've got something for everyone. From tummy tucks to Botox and mommy makeovers to surgery do-overs, the Fuller Butz podcast will surely satisfy your podcast fix. All right, now let's dive into this episode.
Good evening, and welcome back to the Fuller Butz Behind the Scene Plastic Surgery Podcast. Is that the title? I'm Dr. Butz. This is Dr. Fuller, your board certified plastic surgeons. We're back talking about a very common topic, kind of thinking about, kind of just really focusing on that consultation process and how to make that as useful for the patient. We often, kind of have our preconceived notion how a consultation is going. We want patients to be prepared and get the most out of that. So Sam, how have you been, by the way? I feel like we haven't talked in a while.
Doing well. Yeah. The title of our podcast is a bit of a tongue twister. I feel like it gets us every time. And we just want to do a quick and dirty cheat sheet, cliff notes to patients with upcoming breast augmentation consultations. What are the top 5 questions that you should ask, you should know, try to educate, inform, both before the consultation as well as afterwards. So hopefully we can shed some light on what that looks like. Been seeing a lot of patients for breast augmentations, as it were, and going through a lengthy process on implant discussions with the new Motiva implant that's on the market. It's kind of opened up a lengthier discussion on options in my practice, which we'll get to in a few questions. But what about you? Are you changed your practice at all? You're doing some hand surgery, or you're strictly doing breast and body still?
Yeah, still just doing the breast and body stuff. I found my niche, and I just keep making small changes here and there, trying to tweak, learn. Always trying to make it better. Whether that's the recovery, whether it's the consultation, it's all about trying to give the patient a great overall experience from start to finish. And a big part of that is that consultation process, the pre kind of education, to make sure they're fully informed about the choices they're making to help make sure that they're getting the results they want, is really the key thing. So
question number 1 that all patients should ask is, am I a good candidate for breast augmentation? So how would you answer that question to a patient who's asking you if they're a good candidate?
Yeah. So, key thing for any surgery, are you healthy? Are you a good candidate for, most commonly a general anesthetic? It's a short surgery, but, still you want to make sure you're healthy, not going to have a kind of a, anesthesia related complication. Smoking is a big kind of, thing you have to keep an eye out for. Diabetes, those things can kind of impact how things heal. So a lot of that's kind of screened beforehand typically, but making, if there's other underlying health conditions to kind of rule out. Then when it comes down to, your anatomy, obviously if you want a breast augmentation, you likely have, smaller breasts than you desire. Certain anatomies, there's different deformities. Sometimes tuberous breasts are a little bit more complicated. But for the vast majority of patients, they just, lack the fullness they're looking for. And we kind of, lifestyle considerations, or, when it comes to, talked about smoking and kind of some of those things, but also activity levels. And this, I think has changed a lot. Now I talk more about, above the muscle versus below the muscle, depending on their activities. If they're really into fitness and using those pec muscles, I think going subfascial or above can help ensure that there's no, limitations to that. And then looking at, if there's loose skin, do you need a breast lift? And that's really during the exam. Some people have no idea that they need a lift when they come in. They just think they need to be fuller, but in fact, they, kind of, have a lot of droopiness or ptosis. And sometimes that can be a surprise to them, but we don't want to just put in implants and still have this droopy skin, because otherwise that's just not going to look good either. But yeah, did I miss anything?
Very thorough. So it's a combination of their medical history. Can we safely get them through the process? And then does their anatomy dictate that an augmentation is warranted? If they have heavy, dense, pendulous breasts, probably not an implant is needed. So yeah, I think that that's a great first question to ask is, is this the right procedure for me?
Yeah, so the next question is you kind of teased a little bit about the different implants that are now available, but what type of implants do you recommend for your patients? What are the differences, pros and cons?
So, as part of my initial consultation, describe to them a couple of different phases. When we get to discussion of implants, I say that there's largely two different groups. There are saline implants, essentially an empty balloon that's filled with sterile saline, which was very common in the 2000s once there was a moratorium on silicone gel implants until further research was developed. I admittedly tell them that it's been since before COVID since I've put in a saline implant, just because of how common and safe the gel cohesiveness gummy bear implants are. I say that saline implants are great. They're extremely safe. Some of them have this boom or bust where like they can last for 20, 25 years, and other ones within a couple of years can spontaneously deflate, and it's not going to make them sick, but they're going to have one empty breast and one full breast. I also say that because the shell of the saline and the fact that it's just salt water that's there, there's a little bit less natural feel, a little bit more ripple effect or dimpling where you can visibly see the implant and it just doesn't behave or act as natural as what breast tissue or the gel implant is. So then I switch over to discuss the gel implants, and there are four different companies that are in the U.S. that allow for their implants to be used. Discuss some of the pros and cons about each of them, and then I have sample implants that are in the low projection, the moderate projection, the high projection, and really just discuss with them, based on their goals, their body type, how much breast tissue they have, that we can fit them into a different shaped implant based on goals and anatomy. Kind of say that patients who want to look overdone want that augmented look, usually the full or high profile. For patients who already have a lot of breast tissue, just want a little bit of upper pole fullness or volume, have a little bit wider base to their chest wall or their breast, a low or low plus implant can be very helpful. And I would say that the Goldilocks, or kind of that most common that I use, is the moderate implant, or Demi for Motiva, which allows for the benefits of both worlds, where you get the upper pole fullness, but it can still be very athletic and accentuating. For the implants, I actually have, like for Natrel, I have the three different gels, different cohesiveness of them, to show them that you can actually decide what thickness of gel can be used, and usually show them that the thinnest gel is not necessarily my favorite or very common. I think it's there because they can market and say that they have lots and lots of options, but if somebody really wants that, they can. There's the stiffer gel that's on the other side of the pendulum that I say, again, if you want more of an augmented look, want to maintain more of that upper pole fullness, you can do that. And then somewhere in the middle is that smooth, soft touch, which is, again, Goldilocks, moderate, smooth, soft touch, kind of the benefits of the cohesiveness, that upper pole fullness, but it can still move with you. I then compare those now with the newest implant that's on the market with Motivas, and show them their versions of the ergonomics and round implant, and sort of show them some of the benefits that they are marketing as far as the micro texturing of the implant, although it's still considered a smooth implant, the blue seal technology, and the architecture, so that the interconnections between the internal gel and the shell has a closer, tighter interface that may reduce some rippling, may allow for a more natural appearance and shape and behavior as they are laying down, working out, doing all those things. Discuss with them the extremely safety findings between those two implants, and tell them and encourage them that I would let loved ones, family members use these implants, that it's extremely safe. And if we are placing the implant underneath breast tissue, underneath muscle, some of the perks and some of the benefits may not be as crucial to one patient versus the other. So it again has to go on their goals, their wishes, what they like. And I would say if all things are equal, I usually just look at the options on the sheet with them and say, hey, your base width is X, Y, or Z. This specific company has a very nice shape and size for what your goals are and what your shape is, versus one that maybe doesn't have one of those in between sizes for them. Extremely lengthy. I'm sorry, but that was, I blacked out. I think I answered the question, but that's a little bit of what talk about in the office. I'll kind of pause there and let you comment and fill in what I may have missed or what you like to add as well. So hopefully I can learn something too that you've stated, and then I can ask you the next question.
Yeah, no, that was very thorough. Yeah, I mean, I used to have a very similar conversation. I think I tell a lot of patients when talking about saline implants that the vast majority of saline revisions I'm doing, and I put in silicone, people just like how they feel and move with their body better. They just kind of can feel a lot more natural, a lot less of that palpability. It doesn't feel like these firm water balloons. So same, it's very unusual to use saline implants, but maybe if someone has them and like them, and they are less expensive, but that's not a great reason to use them. Yeah, lots of different implant options. Sometimes it can be kind of overwhelming and confusing. So trying to break it down and just trying to find that right implant for their goals is really important. And then, some patients ask about fat. I think we've talked about this in the past, but it just tends to be a much more subtle outcome. So if you're looking for more than a half cup size, implants are going to be a much more reliable way of getting that. But yeah, the Motiva definitely has increased my talking points a little bit, because I think they're both. Natrel, I think, is a great implant. Motiva is a great implant. I think they're both very safe. Some very subtle differences. And it kind of comes down to what the patient likes. It's really important. I think they're both great options.
Yeah, even this past week, I think it was split pretty even between those two companies, and really just try to educate, share. One of the husbands of a patient really deep dived into the numbers and the statistics, which was kind of fun to talk about as far as the longevity of one study, compiling more patients in a different kind of era of implants versus newer ones, and just saying, while it's a brand new implant, it's not. It's been around since 2010 and 6 years of FDA scrutiny to be approved. And I know I have friends who've been part of the research protocol to get approval over the last 5 or 6 years and know that it's and safe. And so it's fun. And I just tell, at that first consultation, it's more about gathering information, not being bombarded and overwhelmed. And I always say that we'll get a roundabout range, but we're going to definitively pick our size or our range of sizes at the next visit, so that we're not really walking out being like, oh, I'm not sure if I should be this size or not. Let's just get to the basics, get to the nitty gritty about what we're actually discussing. And to that point, another question that patients should ask include, what is the risk? What are the risks? What are the complications that can happen following a breast augmentation, Dr. Butz?
Yeah, this is a great question for any surgery you're considering, right? Like any surgery has risk. And we do a lot of things to try to minimize those risks that we'll touch on a little bit as well. I think there's 4 big things to consider with breast augmentation. Obviously, there's always risk of bleeding, infection. Those things are very rare. But the big things, they're not meant to be a lifelong device. So there's kind of a black box warning the FDA put on several years ago. Again, not that they're dangerous, but they want to make sure you're fully informed. So we go through this checklist. At some point you'll likely need a revision. It's not an every 10-year thing. The rupture rates of these newer implants, as low as 2 to 5% at 10 years. And so most revisions are doing 10 to 15 or 20 years that oftentimes just kind of maintain or improve upon the result. The implants are often just fine. Implants, they can rupture. And I just kind of mentioned that. Capsular contraction is a big thing that used to be a much more common issue. It used to be as high as 20 to 30%, but thankfully, due to this whole no-touch technique, where we use these Keller funnels, so nothing touches the implant as it goes in, a lot of special antibiotic irrigations as well, has reduced that to, Motiva's, I think they say 0.6%. Natrel, in my experience, mine's like just under 1%. So it's that isn't nearly as big of an issue than it used to be, which is huge. I think Motiva, one of their big benefits is they kind of came out during the time of no-touch technique, which is, helps their percentages that they published quite a bit. Then something else you obviously going to read about if you're researching breast implants, something called breast implant-associated anaplastic large cell lymphoma, which is this very rare entity associated with kind of the older textured implants, which were much more aggressive. And the goal of those were to kind of help that implant really glue into place. So the scar tissue grew into the implants and didn't move at all. These are the more traditional teardrop shaped implants. And they did this in some round implants as well, but basically it's an overimmune response to that texture. We just, at least my practice, stopped using those. There's still a couple available, but some have been taken off the market. Motiva has this nano texture, smooth silk, which doesn't have that reaction at all. So in 14 years, there have been no cases of that reported, which is definitely important to be aware of. Yeah, and those are the big things. Again, true infections with implants are extraordinarily rare. Again, largely due to probably no-touch technique and just everything else we're doing. Longevity is important. We want that implant to be really stable. Implant malposition, something I talk to patients about quite a bit as well. We're often using internal bra scaffolding meshes to help support things. We don't want the implants to go too low or lateralize. I think underneath the muscle, I really try to emphasize avoiding kind of repetitive chest exercises. They're going to push on the implant, stretch things out over time. And for the first 3 to 6 months, then it's quite stable. And I think the mesh really does help quite a bit as well in different scenarios. So those are the big things. Are there any other things you really kind of go over some other smaller things as well? But
yeah, I would say, just to take a deeper dive into the Motiva, their nano micro texturing is like 4 microns of texture, which is, it's labeled and it's listed as a smooth implant. So it's very much closer to the older textured implants, which were like 15, 20 units of texture. So it's technically not a textured implant. It just has some very at the cell layer, some micro texturing that has shown to decrease inflammation. So I think that's an important topic. I have some patients who feel it and say, "Oh, I thought that textured implants were correlate with the ALCL or something else," and I have to educate them on that, just as you did for us. Another question, I'm going to ask it, Dan. Breast implant illness. So what?
Yes,
what do you tell patients
I forgot something.
Yeah. What do you tell the patients about breast implant illness?
Yeah. So breast implant illness is an association of breast implants to various kind of autoimmune-like symptoms like joint pain, fatigue, rashes, brain fog, memory loss. There's over 100 different symptoms that have been kind of attributed to this, systemic, illness. It's hard to truly pinpoint the implants and this. If you look at all comers, the risk of associating your implants is probably 0.5%. There's over 300,000 augmentations done every year, 150,000 reconstructions with implants every year. So a lot of women are getting implants, and not very many are getting this. The vast majority are very happy. I think it's important to be aware of. That's why I do talk to every patient about this, but I don't think it's anything to be overly concerned about. I think a lot of times it's other autoimmune stuff that would have probably developed anyways. They've done cohort studies of kind of collecting all these patients that think they have that and take up the implants. And some do get a little early kind of rebound of their symptoms. They feel better for about 6 months, but then frequently it comes back, which is, obviously then it's really wasn't the implant, but something else going on. So there's a lot of information out there. There's a lot of rabbit holes patients go down. So you want to be informed about it, but not overly worried about it. What do you tell patients? Something similar?
Yep, well said. Yeah, I just say that it's really hard to correlate that anatomically. As there's silicone, covering pacemakers and other devices that are in the body, so it's hard to say that that's truly unique. But I do say that in my hand and wrist practice, patients get a plate and screw, something in their body. If they feel like it's not agreeing with them, they feel like it's making them stiff, they don't like it. Sometimes we have to remove stuff, and that just happens. I think that you quoted great numbers, in the decimal points as far as that happening. And I think we talk about it way more. Really don't see that in my practice, which is great. But it's just good to inform patients and really just calm them and reassure about all the topics that you can come across on social media.
Yeah, for sure. So, the surgery itself, maybe when you want to talk about, the next question is, where will the incisions be? What will the scars look like? Maybe also, where do you put the implants? You mentioned a little bit below the muscle. Let me go over that.
So I always start with the augmentation by saying, first question is, what incision do we make? In my practice, I really use the inframemory fold incision, very small transverse incision that's made at the fold of the breast so that it's well hidden. That allows us as surgeons to have great exposure to see what we need to see, and allows it to be well hidden and concealed. There are other types of incisions. There's an incision that can be done through the armpit, specialized training, comfort level with that. May have a little bit higher malposition, but can conceivably go in that direction. And then there's also a periareolar, or incision through the breast tissue that's around the nipple. That has been, I would say, frowned upon and used less, just based on the dissection through the breast tissue, which has breast ducts, which communicate with the outside world. And so there's some contaminants, there's some bacteria, can lead to a higher rate of that capsular contracture and infection that you just educated us on. Saw a wonderful patient yesterday who, 16 years ago had saline implants placed through her armpit. Wonderful result, but she was kind of over the rippling, knows that she's due, wanted something that was going to be more natural looking. And so exchanged her implants that were saline for the Motivas is what she selected. Ended up using the inframemory fold incision. I can't go in through her armpit and take out the saline implant and squeeze in the Motiva yet at this time. So she is getting a new incision that's going to be well hidden. Next question that we go through as far as where that incision is where do you put the implant? I really strategically like to place the implant under the muscle. We've talked about this in a few different episodes, but you can either place it above or below. I like it under the muscle, as it's been shown to be an extremely safe position to, again, have a border or barrier between the breast tissue and the outside world with that muscle that's separating the implant. Although with more recent literature, even the subfascial, there's other techniques with the no touch and color funnel. It may not be as important, but I do like to have that muscle coverage above, as I think it creates a very nice natural slope, a nice teardrop shape to the breast for somebody who's lost a lot of weight, doesn't have a lot of breast tissue. If you're placing the implant just underneath the skin and the breast tissue, I think that there's a much more unnatural slope and peak where you have nothing and then you have the implant. And I think that can be a dead giveaway that it's not natural, that as opposed to normal breast tissue. Of course, every patient is unique and different. Need to discuss all of those with them. But in general, I'm talking about a very small 3, 4, 5 centimeter incision that's underneath the breast, closed with dissolvable stitches, no drains. Through that, I'm able to dissect and either elevate the muscle up, place the implant into that pocket, and then close it up very nicely. In general, after an internal bra mesh or woven suture is used to help secure that implant exactly where we want it to be. I know you've dived a little bit more into the subfascial or above the muscle.
Yeah,
patients.
Yeah, there's been a big shift, I think, in the last 2 years. I've seen a lot of our colleagues talking about muscle preservation augmentations and the benefits of that. And my default is still below the muscle for the vast majority of patients for all the reasons you kind of mentioned. But there are some benefits to going above for certain patients. I kind of look at each individual, and it comes down to their anatomy, how much tissue you have to cover that implant. Like you're saying, if you're really thin, you're going to see the round, basically see the outline of the implant. That doesn't look good. I'm seeing a lot of people posting results, that I'm like, well, you can see the implant there. I'm not crazy about that. But I think, like we're talking about, there's a lot of implant options. Someone wants this smaller, more natural result, low plus implant or the Motiva kind of minis. You're not going to see that edge. I mean, you can have, you're not going to see it unless there's nothing there. And if someone's active and that wants to be, I think like fitness, lifting weights has gotten more popular as all the benefits of, muscle building is kind of showing, and kind of just general fitness. You don't want any true muscle limitation. Above the muscle is a little bit easier recovery, and you're going to be able to get back to doing your push-ups, pull-ups, whatever it might be, faster. I have lots of patients below muscle that are doing CrossFit, doing all that stuff just fine. So it's not a guarantee, but you can't say that there's not some difference with how that muscle is going to work if you're releasing a small portion of it. So I think, again, it has having the conversation with the patient, educating and informing them. Again, if they're kind of weighing those pros and cons, you never want to see kind of a little bit of a round edge, safer spots below the muscle. If you have good tissue there, and you're doing push-ups and all that stuff, then above is a very
And
nice.
you want a smaller implant or not?
And small, yeah. So if someone starts getting up to a high profile implant, I'm like, you got to go below the muscle, in my opinion, at this point. I just think it's going to be a safer long-term result. And then, using a lot of internal meshes above and below for just better long-term results support. I think it's probably getting up to 80-90% of augmentations are getting that. So people think about it and look at the results. They like the benefits. Long question answer. Sorry, but it's an important thing to consider. I think it does. I think it's a nice option for the right patient.
Yeah, it's good talking points to share. You want to choose a board certified plastic surgeon, and you want that board certified plastic surgeon to do a procedure they're very comfortable with to achieve reproducible, reliable, consistent results. And you don't want to squeeze everybody into one specific category, but at the same time, you want to, if it's not broke, don't fix it, so to speak. So you want to.
Yeah, I think submuscular dual plane is a safer general option for vascular patients. Again, above the muscle, it's kind of more picking and choosing who's going to be, just the right candidate, because you don't want to see the implant. I don't think that looks good. Again, the older data was that there was higher risk of capsular contraction above the muscle, but I think with, again, no touch technique, maybe this Motiva implants, that's the nanotexture, all those things can help reduce that. What's the next question? Is it my
Another
turn?
question that patients should ask is, what does my recovery look like? What are my post-op restrictions? What do you tell patients at this juncture of the consultation?
Yeah, so I kind of like to break up recovery into 3 different phases. There's that early phase where you're maybe resting mostly and taking pain medications. For augmentations, with or without a lift, sometimes it's just a day or 1 or 2 days. It's pretty short. Trying to get you over to ibuprofen, Tylenol. Just kind of taking it easy with your arms, but doing most of your stuff, avoiding heavy lifting for 2 weeks. With little kids, I often say, be extra careful for the first 3 to 5 days. We want something to start bleeding, then do more bear hugs to pick them up. You can do most things, just kind of be cautious and a little slower than you might normally do. If it feels tight or hurts, don't stretch through it. And then high intensity exercise, say wait 6 weeks. Between 2 and 6 weeks, you can do a lot of light stuff, spinning your legs on Peloton. You can just, but not getting your heart rate up too high, not sweating too much. And there's tape on the incisions for, normally I just take the little IMF, the fold incision tape off at the first week, a little ointment for a few days. And then I like to use Aquaphor for about 4 to 5 weeks from the state of surgery, then go over to scar gel or scar tape. A lot of times though, people do nothing and the scars, you can barely find them at, 6 months, to even less so at a year. They really heal very well there. If you're below the muscle, I'm really trying to focus on, emphasizing, avoiding, certain chest exercises that are going to put a lot of pressure on the implants, because it's repetitive kind of pushing on it is going to stretch things out. During surgery, we make a really tight pocket, but if you're sleeping on your stomach, doing a bunch of push-ups and constantly pushing on that implant, it's that scar tissue, which we don't want it to be too tight, is going to stretch. So wearing good support and really avoiding chest exercises for the first 3 months. Chest focused ones like flies and wide push-ups, things like that. You can do, tricep based push-ups and, kind of modify. And then between 3 and 6, kind of work it back in, but kind of just still take it easy, listen to your body and having good support. I like bras. I tell patients that bras are like a retainer after braces. You want to just stabilize things. Trying to wear it pretty much all the time. I've seen go braless for certain events occasionally, but, trying to invest that or protect that investment, bras are going to help. Even sleeping, gravity's just pulling things to the side for most chest shapes. It's going to be beneficial. So not everyone likes that answer, but there's not a lot of good data to support it. And we like data and whatnot, but it just kind of makes sense to me. Any thoughts, changes, differences?
Yeah, I don't break it up into like trimesters or anything, but I would say it's pretty similar. I tell my patients that you have to invest in the recovery as well as the surgery day. So if you're spending this money and you're going to sabotage it, like we shouldn't do this. That usually requires as you said, 1 to 3 days. I said, when you can be social, you can go out to dinner, you're off of pain meds, you can drive your kids to school, do light activities. I try to limit the strenuous, heavy sweating, arduous, repetitive stuff for about 6 weeks. So I try to keep it under about 10 to 12 pounds for about 6 weeks, depending on how they're doing and feeling. And I would say that there is some unpredictability. Some patients have very little bruising, very little pain, and other patients come in and they're more bruised. It kind of depends on how they're feeling as far as what their activity level is. I know that for mental health and just peace of mind, it's good to exercise. So walking, hopping on a treadmill, a little bit of riding and stuff is encouraged, all with the post-surgical bra that's worn for 6 to 8 weeks, as you said. I love the retainer reference. I'm probably going to steal that from you and use it because, some patients are like, oh, I don't want my implants to fall to the side or something when I'm sleeping. And I'm like, well, at the same time, you don't want like these round orbs that are just stuck on you. When you have natural full breasts, like they also fall to the side. So you want them to have some natural behavior, but at the same time, if you can reinforce that and support that, aside from the internal bra, aside from the restrictions in the surgical procedure, having some sports bra on for the first 4 to 6 months while you're sleeping, avoiding butterfly presses, as you said, for the first 4 or 5 months is recommended. But otherwise, patients tend to love their results, and the time goes by quickly. As much as they're dreading and terrified of not being able to work out for a few weeks, you'll get it all back. It'll pass. And this is a reward for all the hard work with child rearing and pregnancies and weight loss battles and all the above.
Yeah, I think you made a good point. I think a little bit of lateralization is normal. If you have larger breasts, they're going to fall to the side of touch. We obviously don't want them falling. If people talk about them falling in the armpit, that's too much. But if you have a centimeter and a half of lateralization, that's kind of acceptable. If the opposite, if it's too tight of a capsule and they're not moving, that's capsule contraction. So there's gonna be a little bit of implant movement. We obviously don't want too much. It's trying to get that dialed in just right. But some lateralization is very acceptable, and you can't try to prevent all that.
Yeah, I see that in some patients who have implants and we're doing an exchange or revision where, see them and pre-op mark them. And then when they're laying on the table, there's some lateralization, and that's to be expected. Now, if we're having to hoist it up and shove it from the armpit back into the breast pocket, then it needs a capsulorrhaphy or a repair laterally. But if there's just some mild motion, I think that I'd rather take that rather than trying to add stitches and over tighten it to the point where it has more of a boxy appearance or the lateral fold is not as natural.
Right. See a couple bonus questions. We talked a little bit how long do certain implants last? I think we mentioned that already. For future surgeries, what do you tell patients about expectation for longevity of the implants and when they're going to need the next surgery?
So I usually say that, as we both say, the breast implants are not lifelong devices that are meant to be exchanged, replaced. I would say starting at 15 to 20 years should be monitored. And it's a lot easier to come in and say, hey, I need to swap out than waiting too long and having some issue. And so, it's not like has an expiration date like your Wonder Bread that gets moldy a day after that, but it's something that you want to make sure you're aware of. And I usually tell patients, as I told a couple of consults at the end of this past week, if you're 45 and when you're 65, that's a good time to kind of take a look and say, have I gained weight? Have I lost weight? Am I happy in the clothing that I'm in? If you are, then 30-45 minute very cost-effective procedure to get a fresh set would be very helpful. Some patients at that time say, hey, that was fun while I was younger. I don't want them anymore. We can swap it out. But I would say 15 to 20 years for duration. Do you want to give your perspective on patients who are looking to schedule a breast augmentation consultation and they're looking at differences between board certified plastic surgeons and cosmetic surgeons? What's the difference?
Yeah, so I think we've had some of our earlier episodes, we kind of hammered on this a little, maybe too much, but it's important. You want to reach
25 episodes ago, though.
Yeah, it was a long time. You want to find a board certified plastic surgeon who does a lot of these. And, a board certified plastic surgeon goes through, 4 years of medical school, 6 years of residency, and frequently a fellowship. Any person with an MD can say they're a cosmetic surgeon. So, it doesn't really mean anything. There is a board of cosmetic surgery, which isn't recognized. But there's dentists putting in implants. There's, OBGYNs putting in implants. And, some ENT surgeons, so
dermatologists doing massive BBLs and
yeah.
stuff. It's just with 430,000 followers. I'm just like, how is this happening? But go ahead.
Yeah. So, do your research, find a surgeon who's board certified plastic surgeon by the American Board of Plastic Surgery, has gone through the training. His safety is their number one priority, to make sure you get a safe, reliable outcome, and they can then manage complications if they do arise, which I think is important, and to be educated on these things.
I think that's in part why I wouldn't say I'm conservative, but I'm very safe and protective after surgery, because I don't have a bunch of other partners. It's just me. I'm getting all the phone calls. I'm dealing with all these issues. I don't want to have any issues. I want to have very safe, happy patients loving the results for the next 20 years. And we've talked about that with other episodes.
One question that I get a lot in seeing patients who are younger, never really developed breasts like they wanted. What do you tell patients about breastfeeding after augmentation? Should they wait until they're done having children breastfeeding? How do you kind of educate about that?
So I'd say, in general, there's no guarantees in life. And so in research and based on, publications and studies and, just the history of breast augmentation, there should be no interference with breastfeeding. It's extremely safe to have a breast implant and to breastfeed. Nipple sensation in general is the same. A couple of percentage points of having increased, a couple of percentage points of having decreased sensation, but breastfeeding, mammography, all of that should be maintained. I'm going to flip the question back to you, because what I tell young patients in their 20s is like they want to breast augmentation, or should I wait? And just as much as there's no guarantees with breastfeeding, there's also no guarantees that you're going to have this family planning and you're going to have a kid in the next few years. You may be now 32, 35, still, haven't had the body you wanted or the family that you were expecting. And so it's really hard for me to tell them to wait when it's such a safe procedure. What do you tell your younger patients who are considering it, or how do you go through and navigate that consult for patients who are, under 25 thinking about implants?
Yeah, very similar. I tell patients, if you're planning on trying to have kids in the next year or so, maybe it's worth waiting. But if it's kind of more in the 5 to 10 year distant plan, it's hard to know how that'll all work out. And if this is something that's bothering you, you're obviously thinking about it, you're made the effort to come in. This could give you a lot of confidence and benefits over the next 5 to 10 years. And so that's kind of how I describe it and educate them that. And in terms of breastfeeding specifically, again, we're not disrupting the breast tissue at all. It's one of the benefits of that fold incision. We're going either in subfascial below the breast tissue or below the muscle, so it really doesn't impede any of the ducts or ability to breastfeed. And even without implants, a lot of patients struggle to breastfeed, so it's hard to know exactly what might be to blame for that. But yeah, I think, if you're self-conscious about your breast size, you want them to be, different shape, size. Obviously, I always encourage, more natural, not, too big, but it's certainly reasonable to do it before you are done having children.
Yeah, breastfeeding can be challenging with or without implants, but the implants should not impede it significantly. Same thing with breast reductions and breast lifts. Even if we're making incisions around the nipple, removing breast tissue, there are some good studies that show that there's a high, chance and probability, likelihood that you can still breastfeed if you're of childbearing ages. And if you're going through your 20s, you don't want to have that FOMO or fear of missing out and be like, oh man, I lived my last decade wanting a different body. Go out and get it. It's safe, and as long as you do your homework, go to a board certified plastic surgeon, have a thorough consultation, 1 or 2 visits before the procedure to really nail down the perfect size and fit for you. It can be a home run, and there's just to each their own in their perspectives, but I see patients of all different ages, and I'm just excited to be part of the process with them.
Yeah, it's. I feel like it's patients in their. Well, I guess it can be any age, but it's. I feel like the other day it was like a 65-year-old who's just had her tummy tuck and breast dog and lift. She's like, "Why did I wait so long to do this? This was I've been hating this loose skin in my breast size for my entire life essentially." And that's where FOMO, YOLO.
There's YOLO. Yeah, there's a couple of different like peak ages. Like I feel like it's like younger, 30s patients are finally done having kids and then get it then. Then I have some patients who like celebrate their 50th birthday and then they're like, finally my kids are out. I've always wanted this. I'm going to treat myself. And then it's like the in their 60s have always wanted it, and they're all home runs. They're all fun to be a part of the process and to see. And there's not a right or wrong age as long as we're following the protocols and the requirements that are listed. So
yeah. I think we hit a lot of the top things, and hopefully just good bullet points to reference and discuss with your surgeon as well during a consultation. And yeah, we'll keep doing this.
Yeah, it was fun. Great
All
talk.
right. Talk soon.
All right. See ya.
Yeah.
Thanks so much for tuning into this week's episode of Fuller Butts, a behind-the-scenes plastic surgery podcast. Doctors Fuller and Butts are so appreciative of your time and attention. We invite you to subscribe, share, and continue to enjoy our plastic surgery perspective. Feel free to reach out on Instagram at either @FullerSurgeryMD or @DanielButtsMD. That's Butts with a Z for comments, suggestions, and support. Remember, be artsy, stay scientific, and make life fun. We hope you'll join us again on the next episode of Fuller Butts.